Good evening, consultants and fellows on the call. Now, colleagues, you are welcome to today's meeting. Today, we start our presentation with a curriculum presentation by Dr. Victor Anyedi Kenneth on ambulatory ECG and blood pressure monitoring. Dr. Kenneth, please, your audience.
Good evening, consultants, fellows, and my colleagues. Curriculum presents application the ambulatory ECG monitoring types, limitations, and advantages. So we all know that cardiovascular disease is one of the leading causes of morbidity and mortality worldwide, and arrhythmia plays a significant role in this morbidity and mortality. Some arrhythmia are short-lived and cannot be captured by our standard 12-lead electrodes that only record cardiac activity for about 10 seconds. So there was need for development of ambulatory ECG. This ambulatory ECG is Jeff Holter, who invented the first ambulatory ECG machine in 1949. His invention was able to wirelessly transmit electrophysiologic data, but the problem then was that the machine was too large. He used a tube that was weighing about 85 pounds. That's approximately 38.5 kg. Imagine holding that for a whole day. So with the advance of current technologies, advances in technology and software algorithm, this machine has been made smaller, more portable, that one is able to carry about. So that brings us to the modern day ambulatory ECG machine. So, Chief, next slide. Ambulatory ECG monitoring is an essential diagnostic tool that is used for continuous monitoring of cardiac activity over a specified time frame, as short as 24 hours or maybe as long as 3 years. It has gained its usefulness in that it's able to diagnose intermittent and infrequent arrhythmias and also assess cardiac function in patients with non-cardiac comorbidities like chronic obstructive pulmonary disease and end-stage renal disease. So various types of ambulatory ECG monitors are currently available. The indication for ambulatory ECG monitoring as a whole, for class 1, it is indicated in patients with unexplained syncope, near syncope, or episodic dizziness without obvious cause, or patients with unexplained recurrent palpitation. The aim is to correlate this symptom to an arrhythmia, to know whether it's arrhythmia that's responsible for these symptoms. So for class 2B, those patients with episodic shortness of breath, chest pain, or fatigue that's not otherwise explained can get an ambulatory ECG, or patients with neurologic events that we are suspecting transient atrial fibrillation or atrial flutter as a cause. For instance, a patient with embolic stroke, that's the baseline ECG shows normal sinus rhythm, can go ahead, one of the workup for such patients to diagnose whether they are transient atrial fibrillation or flutter. Patients with symptoms such as syncope, near syncope, episodic dizziness or palpitation, now in which potential causes have been identified, and dizziness or palpitation that have been identified by history, physical examination, or laboratory tests. And then for patients with cerebrovascular disease, that's evidence of arrhythmia. It is not also indicated. So the type next slide. Next slide. There are various types of ambulatory monitoring device. They include the Holter monitor, the recorder, which may be post-event, the external loop recorder, implantable loop recorder, or the patch monitors, as well as mobile outpatient cardiac telemetry. So we'll start with the Holter. This is what a Holter machine looks like. The one embed to ensure hold and the one usually from producers. So it's not always placed like this. Different manufacturers may give different direction on how to place the electrodes. So is it clear? Can I be heard well?
It's not the best.
Better,
It's
better
not
now.
the best. But you can be heard now. You go on and off, but you continue.
Yeah, the network is something else.
Okay. So for the Holter monitor, it's the commonest ambulatory ECG monitor that's used in clinical practice. It can continuously monitor and record events for about 24 to 72 hours. This modern day Holter is lightweight, about the size of a deck of cards, can be worn at the waist with a strap or conveniently carried on a pouch. There may be 2, 3, or 12 leads. The commoner ones are the 2 and 3 leads Holter monitor. Those are sufficient to allow for assessment of the cardiac rhythm and identification of the arrhythmia. But for identification, assessment of the origin, an exact site of the arrhythmia would need a 12 lead Holter. If you want to know, oh, is it arrhythmia from the right ventricular outflow tract or other sites, would need the 12 leads. But the 2 or 3 leads conventionally is sufficient to help identify the arrhythmia, the type of rhythm. Because optimal electrode placement, it's one of the key things that must happen for us to have a good data for proper interpretation. One, if the patient is hairy, the client is hairy, you might need to shave part of this the hair off the skin, because this will impede attachments of the electrodes to the chest wall. And if it's not firmly adherent to the chest wall, data quality will be poor. And then if there are dead cells around it, or the skin is oily, that area would be would be cleaned with a rough paper or cloth. And then it's important to use good quality electrodes from airtight package, and then pay attention to expiration dates. We don't want to lose use electrodes that will not firmly attach to the skin. For reinforcement, you can also apply plaster over these electrodes to prevent it from falling off, because this patient is going to be going about his or her routine activity for a whole day, sleeping as well. So those activities can distort and remove the electrodes. So in the electrodes are in the machine are a button called the event mark. This usually helps. The patient is given an instruction to press the mark on the machine, the event mark on the machine, so as to annotate when the arrhythmia or the event occur. Alternatively, the patient can be given a diary to um, write down his or her activities, medication the patient has taken, and what the patient was doing. The time patient had to should be noted. So in the report, what do we expect from a Holter report? We expect to um, have a total heartbeat. So when the patient brings back the machine at the end of the recording period, the information there it's transferred using USB cord to a system that has the software for analyzing the data. So usually for arrhythmia analysis and storage in the system for subsequent interpretation. So we expect to find the total heartbeat, the average heart rate, minimum and maximum heart rate, the number of premature beats in number and percentage as well. The so no need they hold to establish chief next slide to establish the link between palpitation and abnormal heart rhythm. So this is like symptom rhythm correlation. This would be a positive. So if the patient had palpitation, I usually have palpitation every evening. So a patient would benefit from Holter. Let's know whether this is just an anxiety state or a lean person remember our normal ECG probably before the patient gets to obtain a normal 12 leads in our standard 12 leads ECG done. The arrhythmia may have abated and the rhythm might be normal. So for those transient arrhythmia, patients that are occurring at least every 24 hours, patients will benefit from Holter ECG monitoring. Patients with neurologic events when transient atrial fibrillation or flutter is suspected, as already mentioned. It's also used to monitor efficacy and safety of pharmacological and non-pharmacological therapy, as well as detect pro-arrhythmic response to anti-arrhythmic therapy in patients at high risk. It also helps to identify response to anti-arrhythmic medication as well. So it can also be used to analyze the function of pacemaker or other implantable device. Whether the pacemaker is it's important also to assess the PVC burden, knowing that I think more than 10%, burden of more than 10% is clinically significant, and with prolonged duration can cause PV vein. So it's patient with hypertrophic cardiomyopathy now who does a Holter and you see a non-sustained VT. So that's a marker for sudden cardiac death, and patients will benefit from device therapy. So what are the indications for Holter? Is if it's going to delay treatment, hospitalization. For instance, patients with angina pain that would benefit from other modalities of investigation and treatment. So we shouldn't delay it. Say, let's do a Holter to see what it is. Or patients with high syncope and high risk feature that will need immediate treatment shouldn't be placed on a Holter to try to correlate it. Treatment will be more important at that point. Or patients that has symptoms of syncope, near syncope that have been diagnosed through history, physical examination, and laboratory tests. So there will be no need and are responding to treatment from those investigation done. There will be no need for Holter monitor in those patients. Then Cardiac Heart Association has also, next slide, stated that it shouldn't be used routinely to assess as risk assess
Hello, good evening. I think our presenter is having a bit of challenge with the network. We'll give her some time. Hopefully she can join and continue.
hello, can I be heard? Hello?
Yeah, you can be heard now. Kindly continue.
Okay. So we're at contraindication for Holter. So I was saying that American College of Cardiology and American for patients without arrhythmia symptoms, it shouldn't be routinely used to assess risk assessment, even when the patient has cardiovascular risk factor like left ventricular hypertrophy or valvular heart disease, except patients has symptoms of arrhythmia, suggesting arrhythmia. Or if a patient refuses to undergo the test, it's also a contraindication. And it shouldn't be used routinely to screen asymptomatic patients. So what are the restrictions while wearing a Holter? You should avoid bathing or swimming. This will spoil the machine. And avoid X-rays or MRIs. The patient shouldn't go near high voltage supply, magnets or metal detector. as well as you shouldn't operate electric device like microwaves or electric brushes. This will interfere with the recording and the so they one, it's expensive of electrocardiogram. It requires expertise to interpret. It's time consuming. It will take a whole day or more to obtain the data, analyze, and as well interpret. It also requires patient involvement in that the patient will need to consciously avoid those things, keep to the restriction, write down the symptoms, the activities, and also activate the event button. So it requires patient involvement. And most importantly, it does not provide real-time information. So it has the whole process would have to be completed. The transmitted to the software. So it doesn't provide real-time. Inventory ECG monitor will be talking about are the event recorders. So the post-event monitor, this was developed to overcome some of the limitations of the Holter monitor. The image on the as shown on the left is the post-event monitor. The monitor is usually placed as it is shown on the chest wall during episodes of the event. Then the patient has to actively activate the press the button to activate the machine. It has the ability of storing data for just 30 to 150 seconds and then subsequently transmitted for analysis. Actually, the slides are not moving. Okay, that's the post-event monitor I talked about. Hello? Okay, that's the post-event monitor I talked about. So it's usually placed on the chest during the episodes of the event, and then patients will actively activate, press the button for activation, and it stores for about 30 to 150 seconds. The advantages are that when compared to the Holter, it is unobtrusive, it does not affect daily activity of daily living. Patients can go about this activity on this, and it also gives real time because it is captured and transmitted for analysis as soon as the event is over. The disadvantage is that it's not suitable for brief events. Imagine first you have to look for where you place the machine before taking it close to the chest. If it were a very brief event, that would be missed. And it's not also suitable for patients with syncope because it will need conscious patients participation in placing the machine on the chest wall and causing its activation. So it's not suitable for syncope. Chief, can I be heard? Hello?
Yeah, you can be heard now, but it's on and off.
around. It does not affect activity of daily living. Patients can go about its activity, and information are transmitted in real time. Whereas it in this need to the patient needs to activate
Let's give the presenter a bit of time. I think she's still having challenges. If she's unable to get it sorted as soon as well, then we may have to continue with the MC.
Hello, Chief. Can I be
It can be heard, but not the best.
okay? Chief, can I be heard now?
Yes, you
Is
can
it
be
better
heard now.
now?
Yeah, you can be heard better now.
Okay. I'm sorry for the interruptions. Okay, so that was for post-event monitor. The major drawback is that it does not continuously monitor cardiac activity. It needs to be activated and during period of the event. So it's not suitable for patients that have syncope or patients that have brief events. Then for the external loop recorder, we continuously monitor cardiac activity for about 30 days. and can provide back memory. That's saving data that were captured just before the patient pushes the button and after activation of the device. So for 30 seconds prior and 60 seconds after, unlike the post-event monitor. So this is able to give an idea of the onset of the arrhythmia and then some few seconds later. It can be both automatically triggered or patient triggered. So it can be set such that it can be automatically triggered. So it's for patients with syncope. So the another advantage about texting is so it has the ability to start writing on previous data such that it gives for events, recent memories to be stored. That these are subcutaneous to the left parasternal border. They encase two electrodes up on an outer shell. It can monitor events for up to 3 years. It can also be patient activated or programmed to activate itself. So this has the advantage of being not interfering with patient activity. Birthing and all are not restricted, and the patients and the it can also continuously monitor for up to 3 years. So the next monitors are the patch monitors. They are lightweight, just easily stuck on the skin by means of an adhesive bag. It does not require channels or electrodes, so it doesn't obstruct activities. And patients can easily annotate symptoms while pressing a button on the device. It can record events for up to 14 days. The next is the mobile outpatient cardiac telemetry. These are important for continuous monitoring, in as much as it's continuously monitoring for a long period of time. If data can be transmitted in real time and analyzed on a go by transmitting to a central point for easy analysis. So it gives real-time information. And it's also, you can assess arrhythmia burden and most importantly, nocturnal arrhythmia are example of the devices we've talked about and their key features. That brings ambulatory ECG monitoring to an end. We'll continue with um, ambulatory blood pressure monitoring. So for ambulatory blood pressure monitoring, we'll be discussing using the following outline: introduction, indications, procedure, side effects, clinical significance, and conclusion. So it's important to note that blood pressure is an integral part of cardiovascular medicine. Blood pressure value itself can be used to diagnose hypertension and also to assess and evaluate for hypertensive mediated organ damage, which are the asymptomatic effects of hypertension, persistent hypertension on these organs. There are ways of assessing blood pressure. One, intra-arterial blood pressure measurement. That is like the ideal. It gives the true reflection of the blood pressure, the ideal blood pressure. The office blood pressure measurements, either attended or unattended. This is what we do in the hospitals, where a health worker assesses, checks the blood pressure of the patient, or home-based BP measurements. are like the assignments of the take home we usually give to patients to check their blood pressure morning and evening for up to 7 days and check the average of those BP monitoring. And then the topic for today, ambulatory blood pressure measurements. So ambulatory blood pressure measurement is an accurate and reliable measure of blood pressure over a 24-hour period in a setting that reflects patient's usual environment and activity. It is an out-of-office blood pressure monitoring that uses fully automated oscillatory devices. Remember that blood pressure measurements can either be manually done or automated. Manually are those ones that manual measurements are the ones that employ that use mercury in speak or the aneroids. Then this automated are the electronic devices that we use either for home blood pressure monitoring and sometimes currently in the hospital. So ambulatory blood pressure monitoring uses the automated oscillometric device for its measurements, usually for a 24-hour period, and measures BP at set interval. It is noted that it's a better predictor of outcome other than office blood pressure monitor. The advantages is that it gives greater reproducibility of a 24-hour mean blood pressure values. It's closely associated to and predicts mediated in the office blood pressure and mortality. Can I continue?
Yes, go ahead. Go ahead.
Okay. So it's able to identify white coat hypertension and masked hypertension. So I said that white coat hypertension is when the blood pressure meets threshold for diagnosing hypertension in the hospital, but not in outside the hospital measurement. Whereas mass hypertension is the reverse. The threshold for measuring for diagnosing hypertension is met an out of hospital setting, but not during hospital setting. It's able to discriminate between apparent and true resistant hypertension. So because it gives a 24-hour value, would want to know if the patient is truly resistant to it's truly having true resistant hypertension, which is defined as not being able to meet blood pressure target that's persistently more than or equal to 140/90 when the patient has taken 3 or more antihypertensives. So it's able to assess that. It's also able to assess BP characteristics such as 24-hour BP variation. Some people may have early morning surge, and it's also noted that this early morning surge has its own independently has adverse prognostic value. So quantify magnitude of market risk in patient reduction or nocturnal hypertension. So it's able to assess night nocturnal hypertension and dipping status, unlike this is the advantages it has over home blood pressure and office blood pressure measurements. So ambulatory blood pressure measurements may also facilitate identification of daily life hypotensive episodes and also to know whether the patient is on target in between medications. Recordings are usually obtained at 15 to 30 minutes interval during the day, typically at 7 a.m. to 11 p.m., and 30 to 60 minutes interval at night, typically 11 p.m. to 7 a.m. This is different from the 2023 stated that so anyhow in the 30 to 60 minutes interval at night. So the software would provide average BP measurements for daytime, nighttime, and 24 hours. This monitoring stated that we should use the validated BP device and recording should be taken at 15 to 30 minutes interval during the day and 30 to 60 minutes at night. A minimum of 70% usable BP recordings is required, and patients also should keep a diary of activity. It defines hypertension when blood pressure is more than 130/80 over 24 hours or 135/85 for an average daytime measurement or 120/70 for the nighttime average. So this is to remind us that current classification of hypertension is classified as non-elevated, elevated, and hypertension, unlike the previous normal, optimal, elevated, and hypertension. So it's now classified as non-elevated, elevated, and hypertension. This shows different values for office, home BP, and ambulatory BP monitoring. You observe that the values for ambulatory blood pressure monitoring for diagnosing elevated blood pressure and hypertension are less when compared to office blood pressure, but it stated that the alertness, the sympathetic arousal in the presence of a health worker is removed and the white coat effect is removed. So diagnosing elevated blood pressure using ambulatory blood pressure monitoring, it's between 120 to 134 systolic and 70 to 85 diastolic. Then hypertension being greater than 135 millimeters of mercury systolic and greater than 85 millimeters of mercury diastolic for daytime measurements. So values are different for nighttime and average 24 hours measurements. And so what are the indications for doing carrying out a 24-hour ambulatory ECG monitoring? Is more common. So when a patient comes with grade 1 hypertension and office BP and has do not have hypertension mediated organ damage, we should suspect white coat hypertension, and then 24-hour ambulatory monitor is indicated. And then for condition in which max hypertension is more common, especially patients that has high normal office blood pressure and then elevated out of office blood pressure monitoring with evidence of especially with evidence when the patient has evidence of hypertension-mediated organ damage, or patient has high total cardiovascular risk. It can also be indicated to confirm uncontrolled and true resistant hypertension, as well as evaluation of 24-hour BP control, especially in high-risk patients. You want to know the duration the patient is on target when taking this medication. Is it that few hours after medication intake, patient's blood pressure has bounced back up? So evaluating symptoms indicating hypotension, especially in the elderly. It's also used to assess patients suspected to have postural or postprandial hypertension, especially in treated patients, and then also to assess for exaggerated BP response to exercise, which is I think more than 200
Hello, we can't hear again. No. Just
No, it's off again. The network is off.
No. in Okay, so can I be heard?
Yes, please go along. Continue.
Okay, for the it can also be used for patients that are unwilling to perform a reliable or incapable of performing a reliable home blood pressure monitoring. If you think the patient won't be able to simulate what happens at the hospital, adequately take the measurements or put down the correct recording, or the patient is too anxious to carry on a self-measurement, can also be used during pregnancy. So for the procedure, the patient presents in the morning for the procedure. The device is attached. The patient is a belted device and has an arm cuff. Readings are obtained at 15 to 30 minutes interval during the day, typically at 7 a.m. to 11 p.m., and 30 to 60 minutes interval at night, typically at 11 p.m. to 7 a.m. Patient is instructed to write down daily activities, including eating, walking, exercise, drug intake, etc. Patients would require to return at exactly 24 hours to take off the machine and readings extracted to a computer. Not expected to have taken a bed or put off the machine so that adequate information will be obtained. So a minimum of 70% usable BP recording is required for a valid measurement session. And this is translated to more than or equal to 27 measurements over 24 hours, preferably 7 nocturnal readings and 20 daytime reading. However, current data have shown that 8 or more awake or 4 or more sleeping recording may be adequate if more cannot be obtained, unlike in 2023 guideline, where anything less than this 20 daytime and 7 nocturnal readings were not acceptable, but as low as 8 daytime and 4 nighttime recordings can be used currently. So the image here shows what the machine looks like. It comes with 3 cuff size, pediatric, standard, and large cuff size. The machine is attached to the wrist and the cuff to the arm. The information that can be gotten from the machine are average 24-hour blood pressure measurements and the graph tracing, average nighttime blood pressure measurements, average daytime blood pressure measurements, the dipping status and BP variability, even the heart rate. So in 2022, it said less than 20 daytime readings and 7 nighttime reading was not acceptable and the procedure should be repeated. But currently, as low as 8 daytime and 4 nighttime recordings would be accepted. The disadvantage is that it causes pain and discomfort to the skin. It will disrupt sleep and can cause irritation at the site and the BP recordings to hospital visits for analysis. Thank you for listening. And I'm sorry for the interruptions by the network. Network is very poor today in our area.
Thank you very much, Dr. Victor Niedi Kenneth, for the presentation. Despite the interruptions from the internet, we understand that is not a fault of yours. We still had participants on hoping to get you back on because what you were saying was good, and we are grateful. So please, at this point, we ask for contributions, questions from the panelists. Then after that, from members, then we go to the consultants and fellows on the call. So please, let's kindly ask our questions. In case, Kenneth, you are struggling to communicate, if it's possible to respond to the questions in the chat box, you can type it in. Hello? Any questions, please, or contributions? Okay. We have Dr. Kweki on. Sir, please, do you have any contributions?
Yeah, well, not so long contribution, but am I audible?
Yes, sir.
Okay, so I wasn't here from the beginning, but these are area that's very important when you are looking to the MCQ for the exam. I saw the ending part of the discussion when it comes to the ambulatory blood pressure monitoring. I don't know whether she discussed the finding in terms of discussing deeper, non-deeper, reverse deeper, and the different values. So I would think that she will have discussed um, deepers, what are deepers, and non-deepers, and what are the causes, and the relevance of being non-deepers in terms of causing stroke. And you will have also talked about reverse deeper. So these are things that expect for you to talk about. I heard her talking about you should have minimum of 7 in daytime, minimum of 7 in nighttime. So having a total of 17 episodes. So number one question I'll ask is that can you comment more on deepers, non-deepers, reverse deeper? Then when it comes
Okay.
to the you discussed ambulatory ECG also, right?
Yes.
Yeah. So I don't also know whether you discuss most of the findings because that's one of the most commonest tests we do in a patient that comes with palpitation. And some of the findings in terms of when do you see that the SVT is significant? When do you see the ectopic ventricular ectopics are significant? When do you say a pulse is significant in a patient with atrial fibrillation or patient without non-atrial fibrillation? So, yeah, these are some of the things. If you could comment on them, that would be great. Overall, it's a brilliant discussion, at least for the parts I listened to. I heard you talk about issues with disturbing the sleep of the patient. I've really had experience with the patient that had this ambulatory blood pressure monitor, the pad, and the pad patient reacted to it. Patient reacted to it, and we had to start dealing with contact.
Sorry, Chief, I didn't hear you.
Said I've had an experience where, in terms of the complication, when you put the pad on some patient, they could react to it. Patients that have contact dermatitis, that have issues with react to rubber, and that could be
Hello?
another. Hello, can you hear me?
Yes, I can hear now.
Okay, I was saying that some patients have had experience with those reactions to the cough, and sometimes these are the things you must ask so that you can, make sure you don't give such things to such patients. All right, so just respond to the initial one I said. Thank you.
Okay, Chief, I heard the difference and non-difference, but for the PVC burden, that's the only part I heard. I didn't hear the other part of the question. If that for ambulatory ECG, we are accessing PVC burden. The other burdens I didn't hear.
Yeah, PVC and SVT body.
Okay, SVT. Okay, for deepers, it's stated that at night time it should be a reduction of about 10 to 20% of blood pressure of the daytime blood pressure. So if a patient at night has 10 to 20% reduction of its daytime blood pressure, that's the normal finding, and there are deepers. Non-deepers are those that do not have up to 10% reduction in their daytime uh, of their daytime blood pressure at night, whereas reverse dippers, their nighttime blood pressure is even higher than the daytime blood pressure. I don't know if it's the same thing as nocturnal hypertension. And then there are extreme dippers. If the reduction from their daytime blood pressure is more than 20%, they are called extreme dippers. Whereas the reverse dippers, I think I also saw somewhere that they're also called risers or nocturnal hypertension. Then for PVC burden, I saw that PVC burden more than 10% is clinically significant, and their patients are at risk of tachycardia-induced or PVC-induced cardiomyopathy. So I checked for that for SVT. I did not see. I don't know if it's the same. And then for patients with latex allergy, I didn't come across what would do if the patient has latex allergy for ambulatory BP monitor.
Thank you very much for your response. Okay, Dr. Kwaki, please, did you hear her response?
I heard her response. For people with latex allergy, you tend to avoid it. You don't even have to give them anything. Avoid it so that they don't come with allergy.
Okay, sir.
Yeah, that's okay. That's a good response. Thank you. It's a well done. It's a great presentation.
Thank you very much. Let's show appreciations to Dr. Kenneth for the presentation. We'll move to the MCQ pass. Dr. Charles Corey will share the questions and we'll take it from there. Thank you.